Committee will reconvene. Secretary Levine, you may begin. I started to say continue, but you never started.
Thank you, Mr. Chairman. It's an honor to be here today. I had prepared some comments. I'm going to depart a little bit from my prepared comments and sort of get to the crux of what some of our financial challenges are going forward. You've heard good stories this morning about the good things that were done as a result of this grant. There were other grants as well, and Congress and the executive branch have done a lot for the state of Louisiana and New Orleans, and for that we're grateful. We're also grateful for the selection of Craig Fugate to be the administrator of FEMA. I worked with him during the 8 hurricanes that Florida faced in 2004 and 2005, and I don't know a more capable person in the country to lead FEMA. I just want to get to some of the real financing challenges that we've got that really trump all of this, because all of this will become very difficult for us to sustain if we can't solve these specific issues. First, our state faces the largest reduction in federal match in Medicaid in the history of the Medicaid program. January of 2011, our federal match will decrease by 18 percentage points from an 81% match under the stimulus to 63%. That's an annualized loss of $900 million per year that Louisiana will either have to will have to reduce from the expenditures in the program. That's 1/6 of our Medicaid program. On top of that, we face a reduction in our DISH program. You've heard a lot about the low eligibility, the 12% eligibility for adults in Louisiana. Part of the reason for that is we have historically used this public hospital system to provide access for people that were low income. You heard that nearly 95% of our children have insurance coverage, and we have a very low eligibility for adults. That's true because we have this public system. However, the funding for that public system is in jeopardy right now because beginning in July, we'll face what we estimate will be up to a $250 million reduction in our DISH program, a 20% reduction that begins July 1st. So those two issues combined are more than $1 billion reduction to our safety net programs this coming year. We also are facing, obviously, the loss in the Primary Care Access and Stabilization Grant funding. And I just want to tell you a story. My first week on the job, there was a young police officer named Nicola Cotton who was murdered on the job. She was murdered by somebody who had been treated in our institutions, in our mental health institutions in New Orleans, had just been released from a mental health institution. We found that the mental health system in New Orleans and throughout the state of Louisiana has been neglected for 20 years. So the governor and I set out, along with the legislature, and some of them are here today, to establish some major reforms in our mental health system. We passed several laws. One of them we refer to as Nicola's Law, that allows for involuntary outpatient treatment for people who don't take the medications when they're determined to be at harm of risk to themselves or others. We increased funding for mental health by $89 million. We implemented forensic assertive community teams, multi-systemic therapy, functional family therapy, services that had never been offered in New Orleans before that today are being offered. And because we're doing it, and because we've tried to move the standard from institutional care to a community-based model, we're serving 3 times the number of people that have mental health needs. I want to say there was a question earlier about what is Louisiana doing. Let me tell you some of the things that we're doing. First of all, I mentioned we've increased our funding for mental health by $89 million last year, even facing economic challenges that we are facing. The Department of Health and Human Services just put out a press release a couple weeks ago, or put out a statement a couple weeks ago, saying that Louisiana is one of the most efficiently operated Medicaid programs, and it is the model for how to retain coverage for children. We went from 44th in the nation in child immunizations to just a month ago, CDC announcing that we're now 2nd in the nation in child immunizations, pushing our overall healthcare rankings to 47th in the nation. Still very low, but the highest we've ever had since the rankings have been done. So there is forward progress being made. But if we do not solve these challenges, these financial challenges, if this FMAP problem does not get resolved, the consequences will be extremely devastating for our state. And many of the gains that you've seen, particularly the investments that have been made by the federal government, will be, we think, will be in peril. And to be clear, the reason that the federal match is dropping in Medicaid is because of the very things you've done to help us. It's an ironic twist in the formula. The Medicaid matching formula was never designed for states that had major disasters. So what happens is tremendous investments are made, billions of dollars of investment are made in our state. Economic activity occurs. We have a temporary increase in our per capita income. Our per capita income went up 42% from 2005 to 2007, but yet we still have the second highest rate of poverty, and our Medicaid enrollment's the highest it's ever been. And yet, 3 years later, because of the federal formula in law, our match in Medicaid drops as a direct correlation to the increase in the per capita income resulting from the recovery. Mr. Chairman, I know my time is up. I will say that this is help that only this is something that only Congress can resolve, and we literally are asking for Congress to take a good hard look at this to help us with this financing challenge that no state in the history of our union has faced in the Medicaid program's history.
Thank you very much, Mr. Levine. Dr. Career Perry.
Thank you for having me. I am Dr. Joya Career Perry. I'm the Director of Clinical Services of the City of New Orleans, and I'm also an OBGYN.
Your mic on?
I don't know.
Oh, now it is. Hey, you can hear me now. All right. I know it's getting kind of late. I'm Dr. Joya Career Perry. I'm the Director of Clinical Services for the City of New Orleans Health Department, and I'm an OBGYN. I would like to thank the House Committee on Oversight and Government Reform for giving the City of New Orleans an opportunity to speak today, and for providing this funding for primary care access and stabilization. This vital funding helps support the city to reestablish a health system of care, along with providing critically needed medical and mental health services to the greater New Orleans area communities post-Hurricane Katrina. The causes for our historical, social, health disparities as a state, and more specifically in New Orleans, are complex and far-reaching and not easily counteracted. When Katrina made landfall, 28% of New Orleans citizens lived in poverty, 25% had never finished high school, 50% lived in a single-parent home, and 25% had no health insurance. Hurricane Katrina has only exacerbated what was already a fragile health infrastructure and medical service delivery system. The current lack of access to both primary medical care and mental health services for such a large portion of our parish is perhaps the strongest correlate to our repeatedly poor health outcomes. The goal of the New Orleans Health Department is to provide direct medical care services and help to build a sustainable and long-term infrastructure, along with the opportunity for collaboration and coordination in creating an equitable and accessible healthcare system for all residents. Therefore, I'd like to focus on 5 things: the lack of access to primary medical care services by our citizens most in need, the professional and medical and mental health provider shortages, a profound lack of mental health services, health disparities, and the need for continued support to finish the rebuilding of the city's health infrastructure. Today, with the population of New Orleans having reached an estimated 350,000 people, close to 75% of its pre-Katrina numbers, the services offered by the New Orleans Health Department are much less. The city operates only 3 primary care clinics, 1 homeless clinic, 1 fixed dental site, and 2 mobile dental sites. The geographic coverage is limited. One of the primary care clinics is located on the West Bank, and so we have the map up there, kind of little dots. One is located in Central City, and one is in New Orleans East, across a large industrial canal. So I don't know if you look to the right on the map, where there's only a couple of little dots in the far right corner, that's New Orleans East, where our clinic is. There has been a significant decrease in the number of medical, mental health, and dental providers seen in Orleans Parish. According to a 2007 Blue Cross Blue Shield report, only 28% of their original medical professionals returned to practice in Orleans Parish. Last year, the Louisiana Department of Health and Hospitals reported that less than 25% of those providers accepted Medicaid patients. There has never been an adequate mental health infrastructure in New Orleans, and today, the need for care and treatment have only increased exponentially since Katrina made landfall. During the last 4 years, the availability of psychiatric beds have been dramatically reduced, combined with a large number of mental health care providers never returning, which has left the citizens most in need with the most obstacles in receiving care, needing care and treatment. And beyond not being able to meet the mental health needs of our citizens, it has created a cross-cutting effect on families, communities, work sites, and the broader healthcare delivery system, from the hospital emergency rooms to the primary care physicians to the local jail facilities, which today houses the most psychiatric beds in the parish. Just as behaviors and lifestyle choices are the causes of most chronic infectious diseases, access to primary, preventative, and treatment care is what improves health outcomes and decreases disparities gaps. What research has shown is that health disparities in Louisiana are often found in populations which are poor, minority, high school dropouts, low incomes, uninsured, and lack transportation. All right. The New Orleans Health Department identified an extremely high need and underserved and understaffed site within Orleans Parish and responded by establishing a clinic site with PCHG funding. As you can see on the map, it was in New Orleans East. Oh, we went through all my slides, huh? New Orleans East represents approximately 35% of total parish land area and 15% of overall population. Yet 4 years later, there is still no hospital. So just wanted to put up my little Methodist picture. Can't have a New Orleans conversation without talking about the Methodist Hospital. Separated by a large industrial canal, New Orleans East is considered a suburb of the city with the fastest growing part of the parish in terms of population, business, and industry, with a strong increasing middle upper class black population and Vietnamese population. Like all of New Orleans, but particularly New Orleans East, data has shown a significant population shift. Each month that the New Orleans East Clinic has been open, we have seen a 15% increase in patient volume. We currently offer gynecologic, pediatric, adult primary care services, WIC, and Healthy Start. We have collaborations with LSU and Tulane Schools of Medicine for specialty care, diagnostic procedures, and inpatient management. 65% of our patients are uninsured. Our typical patient is a working mother who comes in for WIC services, brings in her children for pediatric services, participates in Healthy Start parenting classes, gets her pap smear and birth control, and has her brother to come in for a blood pressure check. She can get all of this done at this one site in New Orleans East. For a growing population that is geographically isolated, the PCHG funding has allowed us to provide convenient, compassionate services because even with 4 years later, there is still very limited care in the area. Since Katrina, there has also been a severe shortage of dental services. Slide of the dental van. The PCHG funding has allowed us to fill in the gap by staffing 2 mobile dental units. One goes to the senior centers and one goes to the school-based health units. On these units, we provide dental exams, prophies, deep scalings, amalgam, bonding, removable partial dentures, complete dentures, crowns, and bridges. We have an oral surgeon who can help with more difficult cases. We have begun oral health education programs with the schools as well. So you can see one of our vans we're very excited about. We are hopeful that the availability of services plus the student education will span out to beyond the schools and the senior centers in the future, and right now it's filling a significant need. So in closing, I know I'm over. Below are a few recommendations from the City of New Orleans. Number 1, to increase Medicaid eligibility, to increase the number of individuals who qualify for coverage and are insured, to use flexibility within a 1115 waiver for Medicaid for expansion to support the PCHG funding, to expand the number of federally qualified health centers in the region, and to alleviate the disparities in mental health reimbursement. So that's it.
Thank you very much. Mr. Williams?
Mr. Chairman, thank you, and members of the committee, thank you for the opportunity to address this important topic today. I'm employed by the Louisiana Public Health Institute, a nonprofit organization that works statewide to improve health through public-private partnering. LPHI was chosen as the state's local partner in administering the Primary Care Access and Stabilization Grant, and I serve as the director of that program. Today, my testimony will, in my 5 minutes, hopefully, summarize how the grant has been used over the past 2 years towards the grant goals, and discuss the challenges we face in maintaining the gains we've achieved. The catastrophic flooding throughout New Orleans region following Hurricane Katrina wiped out the healthcare safety net, as you've heard about today. There's a map showing the relative flood depths that you could look at in relation to the location of the clinics, which is overlapping. And also, as you've heard today, the clinic representatives here today were among those who spent the first couple of years after Katrina cobbling together resources and trying to get the growing healthcare needs met in the region. Then in July of '07, we received the $100 million Primary Care Access and Stabilization Grant from HHS to stabilize and expand the clinics that were on the brink of failure at that time. And we want to thank you and HHS very much for making that possible. And making it possible under terms that allowed for the use of those funds in a flexible way so that we could be effective towards the goals of the grant. We strive for a healthcare system with a public-private network of primary care clinics as its foundation to facilitate access to the right care delivered in the right place at the right time. And 4 fundamental goals have guided our efforts to use this grant to advance towards this vision. Number 1, increase access to care on a population basis. Number 2, deliver high-quality, evidence-based health care. Number 3, create an organized system of care. And number 4, develop sustainable business entities. Access, quality, systemness, and sustainability have been our mantra. 25 public and private nonprofit organizations in the New Orleans region were eligible to participate in the grant program. The first award of $16.7 million was distributed to the organizations within 2 months after the issuance of the Notice of Grant Award. Supplemental awards have been made every 6 months since then to all 25 entities, and so far $80,275,000 has been distributed. The remaining grant funds will be distributed in December of this year, and the grant funds will be substantially exhausted by September 30th of next year. However, we expect a no-cost extension will be approved by CMS shortly to help the grantees stretch these dollars as far as possible. About 80% of the funds have been spent on personnel and contracts for the provision of direct patient care services, and the remainder on equipment, supplies, facility renovations, and other expenses that support care delivery. Now I'll summarize the status and progress made towards our priority goal to increase access to care on a population basis. The outstanding performance of the 25 participating organizations in this priority goal area has led to an increase in the number of service delivery sites in the region from 67 pre-grant to 93 today. And there's a map you've seen that shows the distribution of all those sites across the region. In addition, they've increased the size of the delivery system by almost 50% in 2 years in terms of patients served. You can look at the next exhibit, which is a graph that shows the increase in patient volume by 6-month period since the beginning of the grant. It's a dramatic growth in a system in such a short period of time. In the past year, they provided primary and mental health care services to nearly 175,000 individuals and to a total of 250,000 since the grant began. In the past year, 42% were uninsured, representing about half of the uninsured in the region, and 25% had Medicaid. More importantly, over 40% of the conditions cared for in the primary care clinics are conditions that would likely require room care if not effectively managed in the outpatient setting. Now on goal number 2, which is deliver high-quality, evidence-based health care, funds all participating clinics met minimum quality improvement benchmarks, such as providing same-day appointments for urgent care. In addition, $3.8 million was set aside for a voluntary quality improvement incentive program in partnership with the National Committee on Quality Assurance, or NCQA. This incentive program rewards clinics that achieve standards set by NCQA in their patient-centered medical home framework. Significantly, 40 of the clinics received NCQA recognition through the incentive program, and this is the highest concentration of such recognized clinics anywhere in the country. And just 2 days ago, we heard that this impressive cross-sector quality improvement effort will receive a national award from NCQA in March of next year. I got one more minute here. I'm going to skip down to goal number 4 on sustainability, which I think is the focus of the hearing here. Substantial improvements in billing practices among the participating organizations have been achieved. For example, 82% of the primary care organizations are now billing Medicaid, Medicare, and/or private insurance. Despite the progress that's been made in this goal area, we estimate that participating provider organizations would face a $30 million annual operating deficit if they were to maintain their current capacity without the help of this grant or some other such source. The projected deficit stems from their mission to serve people who are not covered by any insurance and hence from whom the clinics receive little or no revenue. Over half of the participating organizations depend on grant funds for more than 50% of their operating expenses, and several rely on grant funds for more than 75% of their operating expenses. Organizations caring for the highest portions of uninsured individuals are most at risk, and some of the highest volume and highest quality clinics that you've heard from today have patient populations that include upwards of 70% uninsured individuals. This program was envisioned as a bridge to a more favorable policy environment, and however, it's clear that those conditions are still years away. Unless we work together now to devise and implement solutions to span the gap, the progress that's been made will quickly erode, and the health system recovery in the New Orleans area will take a giant step backwards, resulting in an estimated 30 to 40% reduction in services overall among these organizations. Most organizations will be forced to contract severely, several will likely fail altogether. Many people who currently rely on these clinics will go without care or end up in the emergency room. Meanwhile, if and when relief comes down the road in the form of coverage expansion, the expensive exercise of expanding the healthcare delivery system to handle the new demand will have to be repeated. Now, wouldn't it be more effective and efficient overall to keep this network intact than to let that happen? A desirable result of this hearing would be that all parties involved will redouble their efforts to immediately identify and implement a set of solutions to address these threats. These could include allocation of existing unobligated community development block grant recovery funds for this purpose, granting permission for the state to use Medicaid disproportionate share funds for outpatient primary care and physician services, and exploration of additional sustainable options for funding. It has been an honor today to participate in the hearing, and thank you for your continued support of our efforts to rebuild a healthier, greater New Orleans, and I'd welcome your questions.
Thank you very much. Let me thank all of you for your testimony. Let me begin with you, Dr. Recovery. You know, I'm interested in that van. How does that work? I mean, you go to the same area once a week, twice a week? How does that work? I'm just curious.
So we actually have a MOU with the school-based health clinics. So for the dental, the one that you saw with the children on the van.
Yeah.
So that one goes to the school. So they make a schedule. So the school nurses at the schools will find out which kids need dental services. They send home a packet with all the kids, and their parents fill it out. And then they make a schedule, and they let us know that we're going to have, say, 10 kids the next day, and we usually have a schedule for the week. We right now are rotating between 2 different schools. We go to one school one week and then one school the next week, and then each week we get requests from other schools. I mean, everybody wants it because there's such a need for dental services in the city. So some of the harder parts is just getting through the bureaucracy to make sure that we can get it there and get the services to them. But the kids really do enjoy being able to get the services, because a lot of times we've had kids who hadn't been to the dentist since the storm, and we've been able to take care of them on the dental units. Now, for the senior centers in the city have, it goes to it's 4 different senior centers in the city that it goes to, and it has a schedule that it changes every day from one senior center to the other. So the seniors are more consistent. You know, they know their schedule. They come in, and so it's a lot easier to get the seniors on the dental van than it is sometimes to get the children. Yeah.
Right.
Did I? Yeah.
Dr. Brand. You know, and first of all, I want to thank you for, staying all day and listening to the testimony earlier and then coming and testifying later. You know, I want you to know that when I became subcommittee chair back some years ago, I was going to change the procedure because I wanted agency people to hear in terms of what was being said, because we always have the agency people first. Mm-hmm. And then after that, we bring others in. And after the agency people would testify, everybody would get up and walk out. Mm-hmm. And then when the people who had the problems, then when they testified, nobody from the agency was around to hear it. Mm-hmm. So I was the one who said, from now on, we have the people talk first, and then have the agencies come in afterwards. But I want you to know that your being here all day today has made me sort of rethink this thing, because you've been here and you've listened to the testimony, and I want to ask you, from the committee, you've heard what was said. Do you think it's possible that maybe the agency would think about, let's looking at sort of establishing a sort of group or task force? I don't like the word task force, but a group to sort of work together to see in terms of how we might be able to move some of these efforts along. I know you might not be able to make the decision sitting at the table today, but can you take this back to request that we would like to establish, I guess, a committee to explore ways to continue restoring health care services to the post-Katrina region? You know, I think there's still a lot that needs to be done, and I know you just can't right away say, you know, but the point is that, you know, if you could take that back and let us know in terms of if there's any real interest in this, because, you know, as many members of Congress, you know, along with the representative from the area, that would like to see in terms of what more we might be able to do. And sometimes it's not money, it's just sort of getting things coordinated. And I just want to get your views on it and recognizing that it's not something that you can bang the table and say you'll do, but the point is that will you take that back and think about it?
Yes, sir, and it's been very helpful and interesting to have spent the day listening to my colleagues talk about New Orleans and access to primary health care as it is at this time, and how it's changed compared to immediately before and after Katrina. HRSA and the rest of the department, I think, have worked collaboratively to address these challenges. CMS certainly is the part of the enterprise that looks at payment, but HRSA is concerned about access through health centers, workforce. Our colleagues in SAMHSA would be very interested to hear the challenges that the city still faces in providing access to adequate mental health services, and so certainly, sir, I will take your challenge and your charge back to the department and see what we might do. We have been working together collaboratively, but this might be an opportunity to take a look at that and see what the next phase might most appropriately be.
All right, thank you very much, Dr. Brand. Mr. Levine, can you give me a broad outline of your administration's plan to build a replacement facility for the now shuttered charity hospital? When will construction begin? How will it be financed? And what scope or size? Is there anything that the Congress can do to facilitate this?
Well, thank you, Mr. Chairman. We've taken several steps to move the process along to the extent that we can. Obviously, the financing is the big piece of this that hasn't been resolved. We're still, unfortunately, in the arbitration phase with FEMA at the moment. We believe that the state has made adequate has provided adequate evidence that the state is owed $492 million under the Stafford Act. FEMA's last offer was $150 million, up from the original offer of $26 million or so. We are in the process of acquiring the property. We are in the architects are doing the design planning phase of the project. So all the things that can be done while we work out the financing piece of this is critical. The other thing that we've done is that we've completely changed the model from the old charity public hospital model. We've actually looked at what happened in Atlanta with Grady. We've looked at Tampa General. We looked at other Shands Hospital in Gainesville with the University of Florida. We've looked at models of teaching hospitals that used to be public but have converted to the nonprofit model. And that's what we've done. And we entered a memorandum of understanding between Tulane, LSU, and the state that was signed about 2 or 3 months ago. So all of those pieces have been put in place. The one piece that's not in place is the FEMA piece of this, which is substantial. If we do not, the way the financing is supposed to work is the state's committed $300 million. We had estimated the $492 million from FEMA, and then the difference between that and the $1.1 billion, $1.2 billion was going to be financed through the debt markets. If FEMA doesn't come through with a significant amount of money, if the arbitration doesn't go our way, that could really imperil our ability to finance this hospital. Given the situation, I mean, we would have to finance more than the estimated $400 million we had started that we had planned on. So it's irrespective of whether somebody believes we should rebuild the old hospital or build a new one. It's all academic if we can't get the money from FEMA. And so the question about what Congress can do, to the extent that FEMA falls short due to the arbitration process, if it doesn't go our way, certainly Congress can step in and provide funding that would bridge that gap. We aren't asking for that at this point. That's certainly in the purview of Congress, but we're trying to work within the scope that has been laid out by FEMA.
On that note, I yield to the representative from the area.
Thank you, Mr. Chairman. Mr. Chairman, I'm very glad to hear today from the GAO that we have been using the money responsibly, because traditionally we have had some negative images with respect to how money were being spent. With that being said, I was a little bit disappointed, Dr. Perry, Career Perry, to hear that there are $4 million in for mental health that are left unspent by the city, and you come here to testify of mental health needs. Can you explain with respect to that discrepancy?
Yeah. We don't have money for mental health in the city.
I'm sorry?
We don't have a mental health grant for the city.
I've received information from
Okay.
very secure sources that the
Okay.
city does have $4 million in mental health money left unspent.
I'm not sure.
But can you look into that, if you don't mind?
Yeah. It might
Or
be
Mr. Williams, do you have
SSBC.
any comments with respect to that?
Yeah, I believe it would be a strange coincidence if it wasn't the, if this wasn't the $4 million carve-out from the Primary Care Access Stabilization Grant that was specifically earmarked for the City of New Orleans Health Department to address not just mental health, although that's an allowable expenditure of the primary care grant funds, but also to address healthcare needs in particularly underserved areas, and to provide the dental services which are up and running. They got off to a slow start spending that money, but they're well underway to make good use of it at this point, as far as I know today, and we can get you more
So of the
information
$4
later.
million, which portion of it was spent on mental health, which portion of it was spent on the
Well,
dental trucks?
Yeah, when we applied, we didn't apply specifically for mental health. We could use it for dental and for the New Orleans East Clinic. So we've spent it on dental and New Orleans East Clinic. So we are on track to spend all of our allocation by the end of the grant. We will have no money left.
Okay. Dr. Brand, I was looking at some of the grant allocations that HRSA has granted to the area, and I've noticed that a large portion of it were concentrated in the downtown and uptown area, where the areas around the fringes, the New Orleans East area, St. Bernard, those areas in Wagaman, in West Wego, there have been very little being done for those areas. Can you address that, please?
Certainly, I believe that Administrator Wakefield has begun dialoguing with you and your staff about the fact that those areas do not have ready access to federal qualified health centers. We continue to work with the Primary Care Association to look at those areas where we might, should resources be made available, do a new expansion or provide a new access point. There will not be resources available for a cycle in 2010. We don't know what the situation will be for 2011 because that budget is still being developed. But certainly, we will work with folks in that community. We'll work with the Primary Care Association to help an organization that's ready to stand up and be prepared to either be an FQHC or a look-alike. Be prepared. The other opportunity, should resources be available, is something called a planning grant that helps the community organize and be prepared to apply and perhaps be more successful in that application process.
Mr. Levine, I know that the state has a terrible FMAP problem. Can you please explain to us how would the FMAP problem affect the issue of the poor in the district? And also, I'd like to know whether or not the state has an audit system with respect to how money is being spent by the city as it comes down from the state.
Thank you, Congressman Gao. The FMAP problem is the single biggest problem our state faces right now with financing for the poor. We can't sustain nearly $1 billion a year reduction in our funding for Medicaid. It would trump everything, all of the progress that's been made here, whether we talk about the expansion. I know there's a potential expansion of Medicaid in the reforms. In the House bill, it was 133%, in the Senate, it's 150%. For us to go from where we are today, where currently we have a $275 million deficit in our Medicaid program this year, into a situation next year where we face a $900 million shortfall, and then go into a period where we have to then do an expansion of Medicaid. It couldn't be done. The maintenance of effort requirements under the stimulus and then in both of the House and Senate bills would really put a lot of pressure on provider rates and really, I think, effectively make our program insolvent. And so we really need a solution to this FMAP problem. All of the good work that has been done, what we talked about earlier about potential solutions to the PCASG grant, for instance, allowing us to use CDBG money that's unspent, or applying for a DISH waiver that would allow us to use disproportionate share funding for community-based clinics. We can do those things, but we also have to provide state match. Well, with a decrease in federal match that we're facing, we're not capable of doing that. So I think the fundamental problems here are A, fixing the FMAP problem, B, acknowledging this DISH audit rule and the $250 million per year impact it's going to have on our state, in addition to the FMAP problem, and then third, the $30 million problem we're going to have when this grant runs out in less than a year. These are three converging factors that any one of which would be devastating, but all three of them are virtually impossible for the state to be able to overcome on our own.
And then does the state have an audit system to ensure that money is being spent by the city?
Well, as it relates to funds that come through the department, we
Right.
do. And we have an internal audit function. We also have the ability through our contract to review all such expenditures, as does the legislative auditor, I believe, have the authority to audit any grant funds that come through our department.
Could you provide us with a copy of the audit?
I'm sorry.
Could you provide us with a copy of the audit?
Sure. Now, I won't say that we done any audits at this point? Yes. Yes. The answer is yes.
Mr. Chairman, if you allow me one more question. I know that Dr.
Extend the gentleman's time for another minute.
Thank you very much. I know that Dr. Recovery has addressed the issue of the New Orleans East and the lack of hospitals out there for New Orleans East and St. Bernard. Dr. Brand and Mr. Levine, is there any way both of you or both of your organizations can sit down and discuss the problem and come up with some kind of solution in connection with Tulane and LSU to see how we can address that particular need out there for approximately 120,000 people. 120,000 people right now do not have access to a hospital. I know I live out there in New Orleans East. Mm-hmm. About 2 years ago, I had to drive my father close to 40 minutes to get him to the nearest emergency room. He's a diabetic. And he has some complications, and we had to fight traffic, drive over the high rise, which for the people of New Orleans East almost serve as a psychological block for many of them. So if you could do that, I would really appreciate it.
I think the administration stands ready to work with the Congress, the state, and the local partners to address all service gaps, and certainly we'd be happy to meet with them.
Well, thank you very much. That's all I have, Mr. Chairman.
Thank you very, very much. And let me thank all of you for your testimony. And, of course, you've been very, very helpful. And we look forward to working with you in the days and months ahead. And, of course, to move some of these things forward. And I think that under very difficult circumstances and conditions that you've been able to do some amazing things. And I want you to know we really salute you for that. And again, thank you so much for your testimony.